I'm Dr. Vivek Gupta, Senior Consultant Cardiologist in Apollo Hospital in Delhi. A case which is a recent acute coronary syndrome, had a almost double vessel disease with additional diagonal, but LAD was non-critical. We have done angioplasty, just giving few points which are interesting. I'll show you the angiographic picture. This is the left-sided view. You can see that circumflex has a disease starting from the proximal to mid, but the most important critical lesion is the OM1. And then LAD is also there, disease, but we have to see further. Next view, OM1 is almost 99% or 95%, and you can see the LAD is having a mid LAD about 30%, non-critical lesion, and diagonal is also diseased. Next, but diagonal is not a very big branch, so we can put on the medical treatment. Right, this is again the view, and I would like to show you the right coronary artery, which is the culprit vessel. You can see there is a 99% stenosis giving to TB1 or TB2 flow in the distal segment, but there is disease in the mid segment about 70%, and again further mid to distal about 70%. So we have to choose. We told the family that this patient is requiring 3 stents minimum. Diagonal we thought we will not do it, and then come back to me. This patient can be treated by angioplasty or bypass surgery, but whenever the LAD is almost normal, the most important dictum is that you should try to do angioplasty, and the patient family agreed, and we have done a quick angioplasty, 18 minutes procedure of right coronary artery, and we have done a staging. We would like to do the rest of the circumflex vessel or OM vessel in the later stage. So whenever we start with the procedure, we would like to know the stent size, and we always use the 30mm segment of the dark area of the whisper wire to find out whether 38mm stent will be enough or not. We planned out 2 stents from the beginning, but once we thought that the wire is there, and then we should do the pre-dilatation, and the pre-dilatation 1.5mm. Good pre-dilatation is very, very important. Go near only. Good pre-dilatation is very, very important. Come. Keep going. Next view. And we did the pre-dilatation of the distal segment and also the pre-dilatation of the mid to distal segment. And then we thought the vessel is good size, and we could deploy the stent because we had measured it that 38mm will not be enough. We have done a 43mm long stent from the vascular concept. This is what is the name? Pronova XR stent, 43mm long, and this is, we have done it size. This is 2.5mm diameter, and there is a good immediately after this. The result is good. You can see the result is perfect. We have to do a post dilatation also in the post. We always use the stent booster, and then we have done the stenting with a 3mm into 18mm stent in the mid segment. And of course, very important to find out the location. The precise location is important. And then next view. Next, we have, this is the good view, but we wanted to do a post dilatation in the distal proximal part of the distal stent. So we use the same 3mm balloon to post dilate the proximal segment of the distal segment, and then we have done a post dilatation with a smaller balloon into the proximal stent, going up to almost 20 atmospheric pressure. The final result is perfect. You can see the final result. This makes a lot of difference. This is actually a result which is comparable to any other good vessel, and the final result without wire, as you can see, is a perfect example of doing a good stenting. 2 stents, and you can see the difference between these two. Show this vessel, and this was the before, and this is after. Come back to me. So only 2-3 points which I want to highlight with the help of Basant, who are our technician, and we have done about 18 minutes procedure. This one point is that pre-dilatation is very, very important. A good pre-dilatation will help you to guide even the long stent of 43mm into the distal segment of the right coronary artery or any other artery. Second point is that whenever you plan, you should always try to always have in mind the size of the stent. I was thinking the 38mm will be short, and he also agreed. So we always use the distal part of the wire, the guide wire, which is 30mm segment, to make an idea whether 38mm was enough or not. And actually it was not, and that's why we have used 43mm long disease. And this was perfectly good example. And then of course the mid segment, which was about 70% stenosis, especially in the right lateral view, in the RAO view, and we have done that stenting as well. So good angioplasty requires a good angioplasty requires a good pre-dilatation, a good sizing of the stent, good sizing and post dilatation, which is helped by the stent boost. Show the stent boost on the top part, which is always very good, because then you know how the stent has been deployed. The stent boost is very good because we know the deployment. Come back to me. And once you know, we don't use IVUS or we don't do OCT to find out this. Hemodynamics is well maintained. And come back to me. So the stent boost is very important. We always use after putting the stent, deploying the stent, we always take a stent boost, and which helps in telling us whether a post-stent dilatation is required or not. And we do post-dilatation in both the segment, and the distal vessel, distal stent as well, the proximal segment, and also the proximal stent with another balloon. Thank you very much for watching this video. Good pre-dilatation, a good utilization of intracoronary Nicoran. All these things helps the patient for the recovery. Thank you very much, Dr. Vipapta, along with Mr. Basan from Apollo Hospital in New Delhi on 10th of June 2019, and Mr. Junaid who is doing the recording.